if you don't know me already, but I'm sure you do, I've been around enough now. So my name's Desi. I'm a first contact physio by trade, but I also work as a OT clinical lead for the mental health OTs, and then also the ambassador for allied health professionals in first contact roles. I've also got Sim. Unfortunately, we're having technical issues, so she won't be speaking, but she'll be in the chat, and she is the physician associate ambassador. And then we've got the lovely Paul Wade with us today, who is the advanced practitioner joining us today. So this is where, moving forward, we are here to support. So if there's any questions around, depending which profession as to who you go to, so be it with CPD or obviously the challenges of primary care, please reach out to us. Let's get started. So today, I'm sure, hopefully in the right place, we're going to be talking about elbow pathologies that might present in primary care. Checking or challenging your assessment process and why you do what you do, having a look at the literature on assessment as well as management, but more specific to primary care. And obviously today we're going to look very much within the Nottinghamshire pathways, and then what's our clinical reasoning about ruling out our red flags. Straight in with a case study. 22-year-old female. She's come in today into clinic and said she's fallen off her bike at the weekend. So she was able to get back on and carried on riding home, but now has a lot of pain in her elbow and just can't get it fully straight. Hit me. What kind of questions? What do you want to assess? What are we thinking? There are no trick questions. And the whole point, all this series is all about going back to basics. It's not about to find the weird and wonderful. Sorry, whoever's unmuted. What are you going to want to assess? No, get back on your bike, head back out again. So when we're obviously looking more, or Eve, you're going to help me. Broken bones.
I'll do my best.
Yep.
You don't want to know how she fell?
Yep, you can see the picture. This is how she came off.
That's exactly how she fell.
Yeah.
Okay. Okay. Has she got any loss of sensation in her fingers?
She doesn't, not today.
Okay. That's me done.
Yep. So I can see in the, no, that's good. I like it, Eve. So first of all, we're looking at for broken bones. So we've had a trauma, fallen onto our elbow. That should be our highest spidey sense of what we're looking for. So where is the pain? So exactly what you said. So is it, so that's where I say, I'm going to be pedantic, point to me where it hurts. So is it, are we looking at kind of like forearm? Are we looking at elbow? Are we looking more at like Olecranon? What was the injury? So I've shown you a picture. We're clearly on the hilly part of Nottinghamshire and fallen off our bike. Is there deformity? So in this case, no. Looks like a normal elbow. There's nothing poking out. Generally, they don't wait to primary care if things are sticking out. Severity of the pain, exactly. So are you able to do your day-to-day things? Almost what's brought you in? It's because I can't do this. I can't sleep. Looking at foosh, we're looking more at that. So foosh is that fall out on an outstretched arm. So that's probably where we're looking more at wrist. So in this case, fallen directly, kind of direct impact to elbow joint. Erythema, so red, hot, swollen, bruising. In this case, we have a puffy elbow. Look, feel, move, good. And compare size. So what does it look like? So the main thing is a little bit swollen, or a bit tender to touch, especially on that more lateral aspect. There's no true deformity. And what else do you want to assess? I gave a hint in the actual case. Elbow anatomy, is it intact? So yes, it's how is it looking? So back to basics. Can they flex fully? Can they extend? So I've said loss of extension, and I'd explore why. Is it because it hurts? Is it because it feels like it's blocked and it's stuck? Having a look at pronation, supination. So back to the basics. What can the elbow do? Is it doing it? Exactly what Eve said. Is there anything peripherally going on? So going into wrist, pins and needles, numbness, anything to shoulder, neck? No, we've ruled out. It's just elbow. And then have they worsened since the fall, or has it been the same? Exactly. So I was all right at the time, got back on my bike, but when I got home, it really hurt. So obviously we've got on a bit of an adrenaline pattern. It's now, I just don't want to extend it. So when I'm doing day-to-day tasks. So in this case, I'm going to save you the suspense. So this one, obviously the suspect was there a fracture? I can't confirm that there's not. So got an x-ray of an elbow and it showed a sail sign. So this is just a very specific for this case. And this is known as an anterior fat pad sign. So what can happen is that when there is swelling, it creates a silhouette that looks like a sail on a boat. And that's where it can indicate that there's elbow joint effusion. So in this case, these ones that you might carry on with that more conservative management, but you might consider if it's not getting better to re-x-ray, and then you're asking for specific views, and that's what you would say to the x-ray department. There was a sail sign, and they will do specific views to have a look if there's anything else going on. So this can normally indicate that there's a radial head fracture. So we're looking kind of that lateral aspect for a fracture. Okay. So in the assessment, I think we've covered most of it. So what was the mechanism? Direct blunt here. Bony tenderness, so it's making sure you know your anatomy, so going through radius, ulna, looking up, obviously humerus, you're not going to directly palpate humerus, but checking above and below. Swelling, loss of range, so especially extensions, so that's kind of our key test, is to inform on our decision making. So if we've lost extension, there's 50% of a fracture. So it can be that we have like loose bodies and that there is going to be that actual mechanical block, or again, if there's pain, that's limiting. So if we hurt our elbow, we like to go into our sling position. So that's where naturally we'll get guarding, and that's where we want to differentiate, and we won't know, especially after trauma, until we've ruled out that fracture. And then obviously, as I said, rule out above and below. Simples. So elbow fracture management. So for a non-displaced fracture, that's normally immobilized, so put them in a sling. If they're displaced, obviously that will go to an orthopedic opinion, but your x-ray, that should, if they identify that, that should go through the fracture clinic pathway. That shouldn't come back into primary care. Those that can straighten their elbow, that's where it might get deferred. And that's where a lot of the time it's that watch and wait, and they put the onus on the patient. So if it's no better, then you come back. But obviously we know that sometimes they come back to primary care. If you've seen them, yes, there's no sign of a fracture, or it's got this sign of swelling, but they're not going to do anything different but this kind of rice type management, then you say to the patient, if it gets worse, if that extension isn't getting better, you need to make sure you either tell the fracture clinic or us, depending what their pathway has been, and then escalate that. So you put the onus on them to make sure to come back if it's not getting better. And then when we're looking at more the rehab side of it, we need to make sure that we're getting that range back, and then looking at that strength through range. Pain management, your normal pain management pathway. Any questions on that? Fracture management. Oh. Next case. Mr. Jones has been on a lot of flights recently for work, and he noticed a lump on his elbow. There is no pain. He can do it. He can do all his day-to-day things. He just doesn't like the look of it. What do you want to assess? What do you want to ask?
It's another classic, is it hot, is it swollen situation.
So it's not hot, but there is swelling because I can see a lump. I'm now Mr. Jones. Where on the elbow is which part of the structure? Yep. Swollen, red, angry. And what does it look like? All right. I'm going to show you what it looks like. Here's my lump. Don't like the look of it. It's not very aesthetic. So range of movement, we've got full range of movement. Nothing I can't do. All good. We can flex, we can extend, we can pronate, supinate. It's not hot. It's not red. There is no pain. It feels squishy, not solid. Trauma, no, other than being on flights, that's the only thing I can think that's different. Exactly, Susan. We're looking more at, and Shikran, we're looking more at that bursitis. So Olecranon bursitis, it's quite a common thing that we see, especially, so the ones I normally hear is that on flights, when you're on a really hard surface, prolonged kind of pressure, or when you're at your desk, like you're sitting on your chair and resting on that elbow, you get inflammation at the Olecranon bursa. And that's where it causes it to be inflamed, but normally in a really contained egg. So that's kind of our key telltale that it's going to be this bursitis, such a contained egg, a bit like our prepatellar bursitis, really contained. Everyone's asking exactly the right questions. Is it red, hot, swollen? What are we trying to rule out? Two main things. What are we trying to rule out? Septic, exactly. Infection, septic, what else? Give me another pathology. Unlikely. But if I say we've got swelling, gout, exactly. So they're more inflammatory. So right now, the main thing when you see a bursa in clinic, are we worried that it could be septic? That is the exact question you should be asking yourself. So main thing, you got swelling over that Olecranon bursa contained egg. It can appear over hours to days, and there's normally going to be, look at the pattern. So sitting on flights, I've been, this is the arm I always lean on. And that's where we get that kind of micro irritation, and that's what causes that bursa to be inflamed. And it can go up and down. So it can get worse the more I'm leaning on it, but actually when I leave it alone, it settles itself down. Generally painless. Except for on that kind of full flexion, people might say it's tight, and it's just because there's a big sack of fluid in the way, and that's where it's a little bit more compressed. And it can be difficult to differentiate between that septic and that non-septic. But things to be looking out for: is it actually more tender? Is it red, hot, swollen, like someone's put? Does it look angry? Has it progressively got worse? So you said about kind of time frame. Is there that kind of local cellulitis symptoms? So in my picture, everything else looked normal, but the egg. Are there any abrasions, lacerations? So is actually that the cause? I fell off my bike like the previous case, and actually I grazed myself as well, giving us a site for potential infection. Having a look if there's fever. Are you well in yourself otherwise? Looking at the past medical history. So are they immunocompromised? And again, it might be at the minute there's no sign, it's red hot, signs of infection, but have on that radar, if it gets red hot, swollen, you feel unwell, you must come back. So again, it's putting the onus on the patient of knowing what to look out for if we're looking for those signs of more septic or infection. Management. Most of the time we're going to go RICE: rest, ice, compress, elevate. Compress to an extent. So reduce compression. So I've just kind of contradicted myself. So when I say compression, avoid the aggravant. So if someone's always like leaning on their arm, or on flights leaning like this, that is what's annoying it. A bit like a blister on our foot. You've got to take the shoe off that annoys it, and then the blister will start to go away. But until you take off the aggravant, it will persist. You can use things like NSAIDs where indicated, but it's not a painful thing, and it's going to be more the aggravant that we need to address more than putting anti-inflammatories in. And again, in this case, he's not got pain, so we're not really going to use it other than minimize the aggravator. And it's that reassurance. And once you tell people this is what it is, send them resources and obviously what to look out for, and actually it will settle down quite quickly. But most common thing I've seen in my practice is people don't like the aesthetic part of it. So obviously a lot of patients will ask, oh, can you just not put a pin in it and aspirate it? So we might do that if we're concerned that there may be a risk of infection. That's where we might aspirate it. But obviously you've got that risk benefit conversation to have. So if you put a needle and introduce a site where it could then get infected, is the benefit of knowing, is it infected, is that more than the risk? And a lot of the times the ones that don't look red hot, swollen, no pain, full range, that's probably where it's too much of a risk to actually put a needle in to aspirate it. That's where obviously looking at the research, they're saying about steroid injections, but they're not shown to be any superior to actually the above of that conservative management. So in primary care, that's not something I'd be expecting is to inject or aspirate unless you're concerned. It might be anything like gout or infection, then you might aspirate to assess further to change your management. Any questions on this? Next one. Oh, I didn't do it. I've given it away. So Miss Flowers reports progressive inner elbow symptoms. She's a recreational javelin thrower. And I know I've already given the answers away. The main issue is inner elbow pain with symptoms that go into her hand. She works as a seamstress and loses the ability to grip when she has a handful of buttons. So she can grip at one bit, but not, they keep falling out this part of her hand. However, sewing, pincer, is all normal. So now I've already given you kind of what the pathology is, but what else could you be considering? So inner elbow pain, and this is her hobby and her work. What other pathologies would be going through your mind? So yes, at the minute, neurological symptoms. So that's where at the minute we've got a weakness. And then say, yep, good. Medial epicondylitis, so kind of a golfer's elbow. So that's where we'd get pain on that inside more on grip. Tennis elbows on the outside, golfers will be more that inner side on your flexor muscles. What else? Look at the javelin photo. What else could be going on? So we've looked at grip. I've given away that it's neuro. What other structures are in that area? Can't see any of the photos. Shoulder entrapment, yep, so looking above. Denise, can you see a javelin thrower?
Yes, it may be individuals.
Right. Tendinopathy, so so carpal tunnel, that's obviously what we're saying, a cubital tunnel, sorry. So if you can see me, if I'm doing this a lot, going into this position, what other structure that isn't nerve, that isn't tendon, what else could cause me inner elbow pain? So the other thing to consider, so it's more, that's why I've added in the recreational sport, is having a look at MCL. So you've got a ligament that goes on the inside. So if they're getting pain there and they're doing a lot of this, that's where they'll get that pain. But obviously in your differentials, that's where you kind of reduce that out, because why would that cause hand symptoms in grip? So in the medial aspect, so you've got that medial epicondyle on the inside of that elbow, and that is where your common flexor muscle will attach. So kind of that's where we're looking at the tendinopathy, and it could refer down because that's where the muscle goes. I said MCL would be very local pain and they don't like this movement, but wouldn't cause any onward symptom. Exactly what someone has said, we want to rule out that it's not coming from neck and shoulder. So Miss Flowers has confirmed there are no symptoms that are going down below shoulder. So what we want to explore is where are your symptoms exactly? So is it sharp? Is it dull? Is it tingling? Is it numbness? When you're dropping things, is it after a certain period of time or is it all the time? Is there anything else on grip that you're feeling clumsy? Anything on the other side? So making sure you're looking at that bigger picture. So we've done a talk before more on carpal tunnel. So that's your median nerve on kind of that mid of that wrist. Cubital tunnel would be that inner elbow. So when people hit their funny bone, you're actually hitting that cubital tunnel where that ulnar nerve peeks through. You can get ulnar nerve entrapment more Guyon's canal, which is kind of that little bit below your pisiform, but less common. But again, a similar principle when we're looking at carpal tunnel, similar principles in all those areas. And then again, that's where you're exploring what are the symptoms and what are the deficits. So are we worried about a neurological deficit or a neural irritation? So on assessment, obviously you're asking them about their pain. So she's saying it's on the inner aspect. They'll point to that area as well. And then that's where they might say burning, shooting, tingling, fuzzing, that all those kind of symptoms that you'd expect on the ulnar aspect and kind of into that 4th, 5th finger. So it's knowing that neuroanatomy of where do your nerves go. If they're getting symptoms more into their thumb, unlikely going to be an ulnar nerve or cubital tunnel pathology. So I said fifth finger, and it'll be like half of that fourth finger. Worse when they're at their end range of flexion, because that's in its most stressed position. Extension would ease it. Positive on tinal, so that kind of tinal tap, and it will normally be over that area where it's most superficial. If I did a valgus stress, so that MCL ligament stress, it wouldn't be lax and that wouldn't provoke pain. So that's kind of that differential again. And then ensure you assess your neurology. So myotomes, dermatomes, compare to the other side. Is there a neuro deficit? That would change your management, except for if there's a neuroradicular pain, that's where again your management would change. So going on to keep that assessment a bit further, so the common sites where you'll get compression. So that medial aspect, that cubital tunnel, is the most common at that retinaculum where it goes over. So that's where I've started with that today. But there are 4 other areas that you'll see on that picture where it can get compressed. So as I said, like your Guyon's canal, that is probably your least common. And then you'll get it through that, again, that ulnar side, that is where it will travel through. Going more into neuro, so it's just knowing that the cubital tunnel, that ulnar nerve peripherally, you'll see if the nerve is compromised is wastage of the hypothenar eminence. So kind of that bulky muscle there, that's where you might start seeing almost that dip. It's exactly like carpal tunnel where you'll see it in the thenar eminence, that one on your thumb. Hypothenar is where it will get affected. And that's where it might be getting your patient to put their hands up like so to see if you'll get that divot. You should see that nice plump muscle equal on both sides. And obviously factoring in, are they left or right-handed, but not that there's a clear wastage sign. So the hypothenar muscles, so you're looking kind of at your opposition muscles, your forearm ulnar, like flexor ulnaris muscles. So that's kind of that flexor common belly. That will be your foolproof of going into those flexion type movements, especially that little finger. So can you bend it? Can you touch your other thumb? Can you hold it closed? That is what you're looking for. The sensory side, so the medial 1.5, so kind of your fifth and half of your fourth finger in that palm area. That is kind of that sensation changes. So again, go back to knowing your neuro. Management. So if there's no neurological deficit, so no wasting, no clear weakness, no clear loss of sensation, that would need onward management. So it might be that it needs investigation or an orthopedic opinion. So that is where you would refer on to your tier 2 orthopedics, most likely your MSK tier 2. If we're looking more conservative, what we might do in primary care, conservative treatments is showing that about a 90% success rate, especially in that acute side of things, so kind of less than 3 months, and they'll generally resolve within 2 to 3 months. And like other pathologies, we need to address the why. What has been happening? So my recreational javelin thrower is new to it, and that's where that was the trigger of starting a new sport, going into a lot of grip and a lot of throwing, and that's what provoked it. So have a look, as anything change in their day to day, it's not going to be I did this and it's come on. So we should be doing conservative for at least 3 months for your radicular pains, not, as I said, the ones where there's a neurological deficit. So we want to offload. So as I said earlier, anything more flexed, that's what's going to provoke it. Extension is where you relieve it. So this is a cubital tunnel brace that you'll see in the picture. So it holds your elbow straight. So it might be at night when you're at rest that you put it on. So similar to our carpal tunnel splint, keeping that elbow straight. Consider workplace adaptations. So is it that, again, sitting on those elbows all day long, resting on their elbow this way, and that's what's causing that compromise? Is it that they're doing a lot of grip-based work and these muscles are getting tight and that's what's causing that compromise? A lot of that education. Once people know, they'll know what they need to do to adapt. And that's where, if you've got MSK, FCP physios, that's where they can do a lot more on that education and rehab in that conservative management. Medication, again, we need to treat the why, not just medication to treat the symptoms. Any questions? Nope. So I don't know if I'm going to keep this one hidden in case I've not put an order on it. So my next case, Mr. Ritchie, he works in a bakery. His main role is a decorative piping on cakes. In his spare time, he likes to do DIY. Over months, he has had a worsening outer elbow pain, causing him to drop things and wake up with stiffness to his right elbow. What do you want to assess? What do you want to know? Tennis elbow, why? Swelling, there is no swelling. We're putting tennis elbow in the chat, but why? What is giving you that suspicion? What would your differentials be? So, yeah, so one of the differentials is because it's the lateral aspect. Is pain worse in the morning? It's stiff in the morning, but yes, looking at morning symptoms, there's a repetitive moving pattern, so that's part of that history. What else could it be? What would the differentials be? Arthritis, so osteoarthritis. What would lead us to think there could be arthritis? So in elbows especially, we'd probably want something in their history for us to go on that spidey sense suspicion. Radial humeral bursitis, yep. Think wider, think medical. Wakes up with stiffness. What else might you ask? Try not be so MSK. Inflammatory, good, yep. Range of movement, good. Always due to inactivity. Spondylo, years of repetitive movement, good. Yeah, so that is where it's just always think, again, when the most common thing is I see a lateral elbow pain, that it's going to be tennis elbow. And in this case it is. But that is where just make sure you're not going, oh, it must be this, and going straight down that route. So exactly, it's not red hot swollen, so we're not worried that, like we said earlier, it's not a gout, it's not inflammatory rheumatology type presentation. It could be, well, what's your other elbow? What are your peripheral, like small joints? Oh yeah, they get stiff as well. So it's just not to get closed-minded, because I know what it's like in clinic, you get a lateral elbow, you're like, oh god, this will be a nice patient compared to chronic back pain. But just make sure you don't go that rabbit hole of just saying, oh, it must be this. So exactly, in this case, Mr. Ritchie, he's doing repetitive movement, and that's where your tennis elbow is your common forearm extensor muscles. So it's this action, whereas golfer's elbow is more your grip going into this movement. So that's kind of our differentiation of why we're getting it. So tendinopathy, going back to basics, a tendon attaches a muscle to a bone all over our body. The tendon has so much it can tolerate. So everywhere right now, if you're pain-free, you're within your tolerance. If you overdo it, tendon gets unhappy. So that's where we have kind of our first reactive, I do something, you know, first day of the year, I'm a marathon runner now, having never run. That's where I do an acute spike. My Achilles tendon hurts, but then it resolves quite quickly because I've gone back to my norm. If I keep running, because I'm adamant I'm going to be a marathon runner, that's where I can go more into that disrepair phase of tendinopathies. And then if I keep staying there, that's where more chronic changes will happen and why symptoms can last longer, come on more quickly. So a common pattern with tendinopathies, not just tennis elbow, but all tendons, most people will point to their pain. So my pain is here, and they'll go on the outside. Patellar tendon, they will point to that tendon. Achilles, they'll point to their Achilles. So that's where this principle applies to all of them. So the pain is here. Does it travel? No, it might go down the muscle belly, but otherwise it won't refer up. It won't be neurological really, unless they're almost getting muscles are getting so tight, but it wouldn't cause a neurological deficit. So they will point to it. Tendons, it might feel stiff in the morning, It gets better when you get moving, but when you do too much, it gets angry again. A common thing that you might hear, especially the more chronic it gets. So stiffness, they can still move it, but actually it will resolve within that 30-minute mark once they've got moving, unlike your inflammatory where it will take longer. And that's where, again, you should point and it's one elbow unless they're doing a bilateral activity. So it's quite common with people that use power tools. So that's why I brought in my DIY, is because if you're doing a lot of grip, the vibration, that again can cause it because you're holding that grip. Any questions at the minute? So to assess it, first of all, there's probably a lot that you've gathered in your subjective. So consider that pain onset, exactly what I've said. It's very activity related. Worst on that initial movement, specific area, you point to it. There's generally not much to see. It won't be red, hot, swollen. Tendinopathies aren't inflammatory, so it won't get swollen. You've got your Maudsley test, so you get their third finger and resist it going upwards, and that will bring on their pain here. You've got your Cosen's test where you resist wrist extension. Things that you can do is that brings on pain. Yup, ow. Do an offload. So you basically hold on the muscle belly, push up to basically put slack on the tendon. You do the same again. Oh, that's better. So it shows it just doesn't like that tensile load. And that's a very, very typical tendon. And as always, rule out above and below that we're not worried that it's going to be, think, radial nerve, ridiculous symptoms. And that's where if it's starting to travel, less likely going to be a tendon. This is where management gets a bit different. So generally with tendons, and this is not just tennis elbow, it's about load management. So treating the fire, not the smoke. That's where medication going to have minimal effect because we're not treating the why. Back to my blister on my foot. If I don't take my shoe off, no medication in the world is going to help me. No injection is going to help because I need my shoe off and staying off for it to resolve. So activity modification. So if you're doing your DIY and that's making it worse, is that something that can take a back step right now? At work, I have to continue. I have a quota that I must ice 100 cakes a day, and they're, you know, I won't have a job if I don't do that. Is it that you can put things like Med3 in place to modify that activity or give them a way to keep working? So tendons want stimulus. Rest is not best. Actually, if you deload someone completely, don't use your arm and then go back to normal, that load goes in a spike. So the tendon, its tolerance will go down, you'll go back to normal, and we're actually back in the same place, if not worse, because the tendon's capability has gone down. So what we want to do is go down to be pain-free and then start to introduce load slowly, staying within pain-free limitations. That is the big thing with any tendon, not just elbows. All right, I have to work. There is no chance. I can't have a Med3. They won't allow it. So that's where we use things like epiclasps, so top picture. And it's exactly what I said about with my thumb. You're giving it an offload and slack. So that is not the fix. That is what I would use to keep someone working or to help relieve pain. But that's not how you carry on with your recreational sports. I'd always have a look at what else we could do to not stress it and not carry on with an epiclasp. You'll look at rehabilitation. So is it that muscles are getting tight because they're working so hard and we're not looking at recovery? I would recommend things like heat. The warmer it is, the more mobile. What it doesn't like in the morning is because it's cold, it's stiff. That's why they get pain. Ice, you can use it as a pain relief, but it's not going to help that tendon pathology. It actually wants to be warm and get moving. When we're looking at rehab, so we'd start off with isometric. So can you resist and be pain-free? Yes. If I can resist maximally and be pain-free, that puts us into eccentric, meaning if I have a weight, like in my picture, if I want to lower it down so that the extensors are getting longer while they're getting stronger, the weight should be so heavy I couldn't lift it on my own. Slowly lower it down, so the muscle has to get longer, not just shorter, which is why the pathology came on. Again, that's where physios are very good at this. And then from a medical point of view, just make sure we're ruling out other comorbidities. So what is a reason why our tendon health might not be as good? So that I'm not going to cover that today, but just consider if it's not getting better, what else is going on? What is like diabetes management like? So if symptoms are persisting and they've complied with rehab, so that's the key part. It's not, oh, I've tried it once. They have to be persistent with it because it's something that has gradually come on. It's not going to be a quick fix off. Now, second line treatment, this is what the guidelines say at the minute, but obviously it's who has got what available. So I'm gonna go back and forth. So injection, so there was an RCT completed this year or published this year, comparing steroid injection, PRP, so platelet-rich plasma, and hyaluronic acid. Now, hyaluronic acid is not used definitely not in primary care or PRP. PRP, if people don't know about it, is where you get a high volume of platelet-rich plasma, so it's growth factors, and that's what helps with tissue healing. So that's a secondary care management where they'll extract it, they do the centrifugal process, and then they inject it back in. But that's where they do need a solid rehab plan with it to make sure they get the best use of it. So while it's healing, that we are loading it up again. Steroid injections, again, what we commonly use, it can help with the local inflammatory process, but we know tendinopathies aren't a true inflammatory process, and that it's more of a degenerative condition on that microtrauma to that tendon from overuse. So it can give people like a quick fix, but again, we need to make sure we're addressing what is going on. So that's where, with this case, it's his actual tensile load. What is he doing? Work and his hobby. So the evidence says that it can be beneficial short term, so they're getting pain relief quite quickly, but generally disappears at 3 months and actually has a higher complication rate than other treatment options and doesn't have the long-term benefits as just watch and wait or physio management. The hyaluronic acid, again, it's not NHS funded, and that's where you might see it in primary care, but it's having a look at why you're doing it. So if you're doing a steroid injection, what else have you got in place? Because the medication alone won't be the fix. Dry needling, again, that's been shown to be, there are some studies where it's looking at the effectiveness that compared to steroid injection, and they're saying almost that microtrauma is having the same effect as almost like that PRP. But again, the studies aren't consistent enough to say that it is, yes, this is your second line treatment. Shockwave, again, another one where you're trying to look at restarting that healing process, but needs to be on alongside a rehab. So kind of the moral of the story, you've got these other interventions, but the rehab and the education, the why, that will be the key parts. And obviously in Nottinghamshire, I believe only South Notts, the Connect service, have a shockwave machine unless they go private, but actually shockwave devices are not easy to get by and you need a regular intervention. And again, it's not just a one-off.